Olá e sejam bem-vindos a mais um episódio do LungTalks, um podcast da Sociedade Portuguesa de Pneumologia. Hoje nós estamos no 8º Congresso da ECBIP, ou seja, European Congress of Bronchology and Interventional Pulmonology. Nós estamos no Centro Cultural de Belém, maio, está um lindo dia de sol lá fora, e estamos aqui em Lisboa para apresentar o segundo episódio do podcast. Vamos continuar esta série de episódios dedicados ainda à pneumologia de intervenção, onde vamos tentar abordar de forma descontraída e também informal os temas que estão na linha da frente do desenvolvimento científico e tecnológico. O meu nome é Hélder Novaes e Bastos, sou pneumologista no Hospital de São João, no Porto, e serei o anfitrião desta série. E fiquem connosco aí para uma conversa inspiradora. Hoje temos o prazer de estar na companhia do Dr. Septimiu Murgu para discutir o futuro da pneumologia de intervenção. Hello, Tim.
Hi, Hélder.
It's very good to see you again. Tim Murgu is a professor of medicine at the University of Chicago Medicine in the United States of America, where he is also the program director of Interventional Pulmonology Fellowship. He is currently the clinical simulation director of the American College of Chest Physicians and the immediate past president of American Association of Bronchology and Interventional Pulmonology. Among many other positions, he has been devoting significant time to train chest physicians throughout the world. As myself, I'm including in the group. You trained. You was very open to receive me in Chicago in your center. It was a very joyful day to see robotic cases, Illumicide cases. It was really a really nice experience. So I'm very happy to have you here for this second episode and to discuss the future of interventional pulmonology. So this morning you had a talk about the value of robotic assisted bronchoscopy in diagnosing early stage lung cancer. So that's what we are aiming for, to change the landscape of lung cancer morbidity and mortality. So we need to diagnose earlier. You have established in the United States since 2011, but I think it was the time when the NLST trial was published. So you have a lung cancer screening program widespread nationwide, and you have been working for more than a decade at diagnosing those smaller nodules that appear, upper lobe nodules. So, and you today presented the value of robotic assisted bronchoscopy. Do you think the robotic assisted bronchoscopy will be the future?
Hélder, thanks for having me. I congratulate you for running this podcast. I think it's always easier to listen to a conversation, as we drive or as we go to the gym, then find the time to watch videos, etc. So congrats. I been reflecting a lot on what robotics have done for my practice, because I know there are now 3 systems on the market and all companies are pushing really hard to expand beyond the United States. And I think what I tried to articulate this morning in my lecture, that if we're consistent in the way we report the data from the robots, we do see an increase in diagnostic yield compared with the previous advanced bronchoscopy platforms. So all things being equal, for the studies that are transparent and actually report their pathology results, then applying the same definition, we are seeing an increase in the diagnostic yield. Understanding that doesn't come from direct comparisons, but that's the best kind of comparison we have right now. And I do not expect that in the near future we're going to have a trial that's running one robot versus another, because I suspect it's very hard for companies to sponsor that. Do we diagnose earlier? Yes. There are many people making an argument. There is a stage shift already by applying robotics. And as we're seeing from several papers, including our recent paper, Target, that was just published in Chest, we're going deeper into the lung, closer to the pleura, and reaching out to smaller lesions. And I think these are true facts. And because of that, we expect that it's going to become the norm, as long as the pricing will come down. Preparing for this lecture today, I came across this survey from the WBIP, and I think it's going to be reproduced again, looking at how many people have access to robotic bronchoscopy worldwide. And it's a very small minority, mainly limited to United States and a few centers in Europe and Hong Kong and Canada. So, and I believe Australia is starting, but it's still the richer countries, and the vast majority of pulmonologists still don't have access to it. So yes, there is value in it. It would likely become the norm for diagnosing pulmonary nodules, as long as the cost is being somewhat mitigated.
Do you know, can you share with us how much would be, I have an idea how much would be the cost, because the cost is not just the platform, it's also the each case, and then the management, I mean the package of maintenance, and so it's how much would cost each patient. In the United States will be different than in Europe, I know, but
it's so difficult because, and I'm not avoiding I'm not avoiding an answer here. It's just very difficult for me for a variety of reasons. I know the bronchoscopes are anywhere between $2,000 and $4,000, but a lot of it depends on what other adjuvant modalities are people using for these technologies. Because you buy the robotic system, you buy the bronchoscopes, and then some have what I call integration with three-dimensional imaging, like CT scans. But it's not like that comes with the deal. You need to buy the CT scanner separately with two of the platforms. With one of them, you just need a regular C-arm. So if people already have an existing mobile CT scan, or I suspect every bronchoscopy lab these days, modern bronchoscopy lab, has a C-arm, then yes, then you just buy the platform. But if you don't have a CT scanner, then I think people need to be honest and declare that we're selling you the robot, we're selling you the disposables, but you also need the 3D CT. Because you hear this terminology in conferences that it's integrated, but you buy the two systems separately. I cannot comment any further on costs. I'm hearing that prices are going up for people who have robotic systems in Europe. I'm just not the best person to have that conversation. Mm-hmm. Also because a lot of it is a contract negotiation at the local level.
Oh yeah, I understand. So you mentioned the target study. Yeah, so you have impressive results. You reached the median lesion size was 21 millimeters. The mean distance to pleura was 5 millimeters. Wouldn't this be more reachable through the percutaneous biopsy? So which cases do you or did you quit 100% the percutaneous approach?
Yeah. So thanks for asking that question, because that's actually a topic that's very dear to me. For diagnosing highly suspected lung cancer, I believe at this time that we should move away from CT-guided biopsy and go for bronchoscopy for a variety of reasons. The yield seems to be quite high when it comes to diagnosing peripheral lesions, now from several trials. And in fact, in an abstract form, the Veritas study was presented, and I believe is soon to be published, that the yield may actually be very similar when you compare electromagnetic navigation with CT-guided biopsy. So if the diagnostic yield is looking the same, then why not reduce the complication rate by a factor of 10? Because we know the pneumothorax rate is about 20% with CT-guided biopsy and about 2% or so with the robotic bronchoscopy or advanced bronchoscopy platforms. So the complication rate from pneumothorax standpoint is lower. In addition, I think what people don't always pay attention to in the CT-guided biopsy literature, there are other complications, and there is a paper by Anil Vachani looking at thousands of patients, Medicare beneficiaries in the United States, that show that there is a 3.6% risk of hemorrhage. There is a almost 7% risk of hospitalization within 7 days after the procedure. There are even cases of air embolism with a CT-guided biopsy. So if the diagnostic yield is the same. It seems like reproducible data is starting to show that it's the same as CT-guided biopsy using the same definitions, because the CT-guided biopsy literature has the same problem.
The next topic.
Yeah.
So,
but using the same definition, then why not reduce the complication rate? In addition, 2 more points on that. With CT-guided biopsy, we don't get any staging information. So patient gets a diagnosis and then has to go for an EBUS procedure. Since the vast majority of patients will require staging, and we can debate like if that's everybody, but increasingly people are doing that. And then there are three meta-analyses actually now, but the one that I recall in more detail, which I showed this morning, is the one that was published in Thorax in 2021, showing that there is risk of seeding the needle tract after a CT-guided biopsy, and people are developing ipsilateral pleural metastases, recurrence, which it's a hazard ratio of 2.5 compared with people who had a bronchoscopic biopsy or VATS. So that phenomenon has not been described yet with bronch or with VATS, but has been described with a CT-guided biopsy in a meta-analysis with a follow-up of 5 years. So it's becoming very concerning. If the risk is higher, if you don't get any staging information, if there is this concern for seeding, why, and the yield is about the same as with an advanced bronchoscopy platform like robots, then why should we do CT-guided biopsy? For primary lung cancer. For confirming the metastatic lesion in somebody with an extrathoracic tumor that has a pulmonary nodule and the risk for a metastasis is very high, you could debate that all these other factors may not matter that much. And by the way, to be also honest, when we cite the number of 20%, 23% risk of pneumothorax, that's if they go through the parenchyma. For lesions that are really touching the chest wall, the risk is not that high for CT-guided biopsy.
So in those cases, we might argue that you can use ultrasound guided for those touching the pleural, ultrasound guided, and we also respiratory physicians are more and more performing this across the world. And so going to the diagnostic yield of the target study, because I know previously we have discussed depending on the definition criteria you use, so you have published 62% diagnostic yield with the robotic bronchoscopy, robotic guided or assisted bronchoscopy of 62%, which is, you know, it is fair, but lower than the few diagnostic yield rates that have been reported. So you applied different definition criteria, so diagnostic yield can go in the same patients of target study as high as 85%. So what is the difference? Because this is very important when we have to decide which approach we will use to diagnose.
Yeah. So it's interesting, right? Because
you reached 99% of the lesions.
Yes, with the robot, and we got the radial signal in 91% of people. So for somebody who doesn't have a good understanding of the issue of diagnostic yield definitions, they may look at that and say, "Oh, this robotic platform has a diagnostic yield of 62%, and look, this platform, based on another presentation that just followed mine this morning, shows 91%. So like that robot is bad, the other one is really good." That's
the same platforms?
No, they are different platforms.
Okay.
But even for the same platform, people are reporting higher yield than 62%. So what is different about our paper? First, it's a large number. So we don't need to be statisticians to understand the problem with small numbers. When we report case series of 20, 30, 100 patients, it's not the same conclusion as when we study 715 patients. We actually screened 715, and the full analysis set was 657.
Yeah.
So it's the largest robotic bronchoscopy study to date, not done only in an academic center with a high cancer prevalence. These were 21 centers in the United States, Canada, and Hong Kong. So it's reflecting more of a real practice than an institution bias report. And in addition, we use very, very strict definitions when we mention the 62%, which means basically we call the diagnostic material diagnostic if there was cancer, if there was a benign diagnosis that was clearly specific and actionable, like a granulomatous disease, caseating or non-caseating, or an infection with an organism, something that was actionable. Not acute and chronic inflammation, not fibroelastic scar, and not multinucleated giant cells. All these were atypical cells included. They are all categorized as non-specific benign. And in the strict definition, we exclude those cases. If you look at the majority, the vast majority of the papers out there on advanced bronchoscopy, electromagnetic navigation, robotic, with the intuitive, with the galaxy, with like there are several papers out there, and some monarch papers too, prior to this study. They use definitions that include those patients. They even include patients who had a completely non-diagnostic procedure where people biopsied lung parenchyma, but the lesion subsequently disappeared on the follow-up scans. So even though the robot took you in the wrong place, because the lesion disappeared, they consider that as a diagnostic material. And then we're also including in the denominator, we included all bronchoscopies, while some people are excluding patients who they had to stop the procedure for whatever reason, or they lost the follow-up of the patients during the follow-up.
So included those patients who did interrupt the procedure? That's what you meant?
We included everyone who had a robotic bronchoscopy. So that's, the denominator obviously becomes bigger.
Yeah.
So that's, I think that's what's unique about this paper. When you mentioned the yield of 84%, is if we apply prior definitions, like the definition in the Navigate study, which I was part of. I'm a co-author of that paper. And there was a loose definition. It was the most liberal definition, if you want, where we included non-specific benign. We included these non-diagnostic biopsies that on follow-up scans, the nodules disappeared. And we excluded people from the denominator, people who were lost to follow-up. So it comes down to looking at the methodology very, very carefully to see if people have applied similar definitions when we start comparing one platform versus another. So yes, for the target study, it's very strict definition yield, 62%. If we go loose, it's like 84%.
Yeah.
Which is insane.
Yeah, it's quite different. But then in those cases, did you combine with the EBUS all these patients? So you're mentioning before EBUS. There are two questions in the same. So EBUS TBNA might also improve the diagnostic yield of the whole procedure for one hand, and the other hand. So even in these cases with smaller nodules, are you performing routinely EBUS TBNA? Because do we need an update in our recommendations? The European recommendations say it's 3 centimeters or N1 staging or the positive PET, PET CT nodules positive. We would perform in those 4 cases the
EBUS staging.
EBUS staging.
So I think the first question you asked me, Helder, was if in our robotic paper we performed EBUS TBNA, and that was done in 50+% of patients. If EBUS was done first and the diagnosis was made, those patients were excluded. You can look at the diagram, and those are not included, right? Because you didn't even need to do the robot. They were scheduled for the robotic bronch, but you got the diagnosis on EBUS, you're done. Yeah. But the second question I think is more interesting. Do we stage other patients other than what's recommended by the guidelines, which now they are getting old? So the current guideline says, Helder, as you pointed out, it's clinical N1, so hilar, interlobar, ipsilateral, right? Tumor larger than 3 centimeters or central tumor. We have several papers now in the literature published since the guidelines came out that even T1 lesions, regardless where they are, central or peripheral, have a single to double-digit percentage, depending on how you read, anywhere between 6 and like 12% I've seen, risk of N2 disease. So if one paper that I recall from CHEST, the authors clearly conclude that we should expand the staging to T1 lesions as well. Even for those people who go for surgery, because again, in like 10, 12% of patients, we may actually find N2 disease, which clearly will be a 3A. But I would make another argument. Sometimes as pulmonologists, when we see patients in clinic and then we schedule them for a bronch, prior to a visit to the surgeon, we don't always know if they are surgical candidates. So if that's the case, if we don't stage the mediastinum and the hilar and interlobar lymph nodes, those patients will go for radiation, SBRT, and they were never staged. And what happens during the follow-up, there is data for that, the local regional recurrence is in the range of about 15%. Yeah. By local regional, I mean at the site of radiation and the regional lymph nodes. Yeah. So then my question to us is, was it truly a recurrence? Or were the lymph nodes positive to begin with? And we don't know because they were never sampled.
Yeah, that's an important issue nowadays because we have new treatment regimens with the perioperative chemoimmunotherapy for the early stage lung cancer. So that's very, very important to know if patients will go undergo upfront surgery or will just start with neoadjuvant therapy. That's very important. And also with the 9th TNM classification, that's another issue. So this with busy bronchoscopy suites we all have. So this will be really a challenge because how much do you take to take a proper EBUS mediastinal staging? How long does it take? 20 minutes? Because the trials say 20 minutes, but I think hardly these 20 minutes. Some trials say, oh, it's 20, 25, and if they undergo through the transesophageal route, it's an additional 10 minutes, but I think it's longer. I mean, it's will really increase the time of each procedure at the bronchoscopy suite. So, and we have busy schedule. I do not think my procedures of EBUS stagings are 20 minutes. I think they are double of that. For a systematic staging of the mediastinum, where we inspect 5 mediastinal stations, that doesn't mean we're sampling 5 nodes, because just so happens for lung cancer, the upper peritracheals are not that commonly involved. So we don't usually see larger lymph nodes larger than 5 millimeter in those stations. But you always screen those.
We should look, and the easiest way to do that, the tube is in, you look at the lymph nodes in the upper region. If there is nothing, then secure your tube further down, and then you start investigating the peritracheal, pericardial, right? Like 4R, 4L7. Yeah. And the majority of patients, those are the lymph nodes we biopsy. But really what our surgeons are expecting is to report investigating the lymph nodes that they would sample during a mediastinoscopy, which is 2R2R, 2R2L, 4R4L, and 7. So that's, to just do that, that's the mediastinum. If you add the ipsilateral N1s, like the 11s and 10s, how can that last 20 minutes? Maybe without rapid on-site evaluation, you could make the argument that that's feasible. I just think speed is not necessarily a factor here. We want to be very thorough to make sure that we offer patients the best staging possible. And
there is another increased value of rows with rapid on-site examination with a new classification, because it's different to the stage N2A, single N2 station, or N2B, multiple level N2 stations. So rows gains a new role again.
It will help a lot to have rows based on the TNM9. But what's really interesting, and yesterday at this Congress, there was an interesting session about, do we change the needle between ipsilateral mediastinal nodes? So for moving from one N2 node to the other N2 node, do we need to change the needle? And people show the data that just flushing the needle with saline and air, and even flushing it 3 times, there is still cross-contamination. So if we're really serious about labeling a patient with multiple N2 nodes, so N2B, we're going to have to change the needle. But what transpired in yesterday's conversation, and I have to do my homework and look at those papers carefully, because I'm more confused now than I was before I came here, because we've been changing the needles routinely for a while now, since the TNM proposal came out. Now it's in place, but the proposal dates back several years. So I've been changing needles, moving from one N2 to the second N2 to confirm N2B. But what's becoming clear in the times of neoadjuvant chemo IO is that people with multiple N2 nodes are still going for treatment and eventually surgery. So the challenge I'm having, which I haven't answered yet for myself and for our institution, is do we make a difference for treatment? Clearly, based on TNM9, we know that the Kaplan-Meier survival curve diverges. That's why we have N2A and N2B. But do we actually affect treatment or not? And I'm not sure yet, because the TNM9, they started capturing data and look at studies prior to chemo IO as a neoadjuvant modality. So I think we're gonna have to have more conversations like this in meetings like this, and dig into dive deeper into the data to see if that's truly impacting management or is just more of a prognostic information based on older studies.
Yeah. Just one final question, because I think it goes along with what we have been discussing in the last few minutes, and with the we start with the robotic bronchoscopy for diagnosis. I just want one brief comment about the treatment using the robotic assisted platforms, because this is an episode about the future. So interventional pulmonology, the future. So and that will be a great opportunity for respiratory physicians. I don't know, one-day clinic doing diagnosis, staging, and treatment, perhaps someday. There are reports doing that. Most of the reports I've read are from China. Do you in the United States already have those settings? What do you feel will be the future regarding robotic assisted bronchoscopy for treatment?
Yeah, it's an important question, Helder. And in the United States, no technology was approved for that indication yet. There are trials that people are running. If we go to clinicaltrials.gov, you'll see a variety of trials for looking at microwave ablation, cryoablation, photodynamic therapy, vapors, and most of the data is on microwave ablation, actually. So I can comment on what my interpretation of the data is. People report immediate response, and then 12 months recurrence rate, anywhere between 4 and 10%, with one study showing that at 33 months, the recurrence rate was almost 27%. So I wonder if this is truly an alternative to surgery. And we can speculate why, at least based on these small reports that we have right now, the numbers are looking worse than with sublobar resection. I think one reason is, for me, we are not sampling N1 nodes that are deeper than station 11 and 12, maybe. We kind of stop. Now, maybe with the smaller EBA scopes that are coming out, and by the way, no conflict of interest with any of these companies, but with the smaller scopes, if we get closer to the lesion and we find station 12, 13, 14, then we can label the patients with having an N1 disease with those subsegmental lymph nodes that may not be candidates for a bronchoscopic ablation. Because I'm trying to explain why we're seeing, with the papers that are reporting longer follow-up, a pretty significant recurrence rate. It's probably because they burned the tumor, but they did nothing for the lymph nodes around them. We sample with EBUS routinely, station 10 and 11, and sometimes, if you're very diligent, you can get to a 12, which is the intralobar. But what about the segmental, subsegmental? The size of the EBUS scope right now does not allow us to go that deep. I'm not skeptical. I just think we need proper information and clear studies before we start doing this to patients, because we know already that microwave ablation has hurt a few people, and there were trials looking at bronchoscopic microwave ablation that had to be aborted because of massive hemorrhage. So we have to do this in a, I know it's a cliche, but we're going to have to do it in a prospective multi-center study. And ideally, we need to have a comparator like SBRT.
Thank you, Tim. Thank you for your time. It was great to see you again.
Always a pleasure.
I think this will be, it was a really insightful conversation, and a good episode. And now just moving to Portuguese to say hello and say goodbye.
Thank you for having me.
E obrigado a todos que estiveram a assistir, e continuamos por aqui para o próximo episódio. Vamos falar sobre, não vou revelar, fiquem por aí.